Good afternoon, everyone. Thank you all for joining us for the last day of this two-week ASNC virtual nuclear cardiology elective. I'm very pleased and honored to introduce today my colleague and mentor, Dr. Marcelo Di Carli. He is the Chief of Nuclear Medicine and the Executive Director of the CV Imaging Program at the Brigham and Women's Hospital. And he is a professor of radiology and medicine at Harvard Medical School. He is also the current president of the Imaging Council of the American College of Cardiology. So Dr. Di Carli will walk us through evaluation of coronary microvascular dysfunction. And after his talk has completed, I just want to close the session with a few closing remarks from ASNC. Marcelo, you're on. Thank you very much for joining us today.
Thank you, Sharmila. I hope you hear me okay.
Yes, we hear you well.
Okay, so welcome everyone. This is my first virtual reading session, so we'll see how that goes. I want to begin by thanking ASNC for this and especially Sharmila Dorbala for organizing this wonderful opportunity for all the trainees around the world, and for giving me the opportunity to share a reading session with you. I also want to thank each and every one of you for everything you're doing during the crisis, wherever you are. I know everyone's busy, and so we're going to try to make your time here as worthwhile as possible. So my topic for the didactic was coronary microvascular dysfunction. And so I'm going to show you just a primer on coronary microvascular disease, and then we're going to move on to cases. And in the cases, we're going to try to apply some of the concepts that we reviewed during the presentation. I think here are my disclosures, but they really have no relevance to the topic that I'm going to be reviewing today. So the first question is, what is coronary microvascular disease? And in simple terms, if you actually go to the Brangwald textbook, you see that coronary microvascular disease is defined as heart disease that affects the structure and the function of the small coronary artery vessels of the heart. It leads to myocardial ischemia and sometimes injury symptoms, and is always associated with adverse clinical outcomes. So why is it important to know something about coronary microvascular disease? There are several reasons why. One of them is that the absence of obstructive stenosis in the coronary angiogram, which has been for many years the way in which we diagnose the presence of coronary heart disease, fails to explain symptoms or risk in many patients with stable chest pain. And this is well illustrated in this large registry from Scandinavia, including over 11,000 patients undergoing coronary angiography for the diagnosis of chest pain. And what you can see is that in both in men and in women, there was a significant fraction of patients in whom, despite the presence of chest pain, there was no obvious presence of obstructive stenosis on the coronary angiogram. This was the case in about 1/3 of men and in about 2/3 of women. Now, the absence of coronary artery stenosis was not necessarily associated with low risk. And you can see here that the presence of chest pain with normal coronaries was associated with increased risk, and the presence of diffuse non-obstructive coronary disease the same. So the holy grail of making diagnosis of coronary heart disease has really failed in uncovering the presence of ischemic heart disease in many patients, both men and women. Just to put that in additional context, here's data from 4 large clinical trials of coronary artery disease, randomizing patients to medical therapy or revascularization. And you can see that the angina was a frequent finding 1 year after randomization, especially in those undergoing coronary angiography and revascularization. And you can see that the frequency of angina range from anywhere from 20% to about 50% in the COURAGE trial. So meaning that despite the fact that we have revascularized the so-called culprit lesion on the coronary angiogram, we failed to improve symptoms in a significant number of patients, particularly those with obesity and diabetes. You're familiar with the Orbiter trial, showing that the change in symptoms was not necessarily related to the revascularization of unobstructive coronary lesions. And so again, 20 to 50% of patients continue to have angina at 1 year after revascularizations in large randomized clinical trials, suggesting that there is a residual microvascular risk after revascularization has been performed, which explains in part the residual symptoms in those patients. The other compounding element here is that the epidemiology of cardiovascular disease is changing. The incidence of atherothrombotic plaque rupture causing ST elevation MI is decreasing. The hospitalization rate for secondary causes of myocardial infarction and heart failure with preserved ejection fraction are on the rise. And all of that is in the context of an increased prevalence of obesity, glucose intolerance, and diabetes and older age, all important risk factors for coronary microvascular disease. So what's the pathophysiology of these syndrome? Well, here's a schematic of what you see in the epicardial coronaries on the top panel and on the microvasculature in the lower panel. And what you see is that in the large vessels of the heart, we typically see focal stenosis or diffuse atherosclerosis as the main pathophysiology of ischemia. In the small vessels of the heart, what you see are 2 types of changes. There are structural changes, including intimal thickening, smooth muscle thickening, and proliferation, both of which produce a phenotype of obstructive coronary disease similar to what you see of diffuse disease in the epicardial coronaries. In addition, you have capillary rarefaction, which is a reduction in the cross-sectional area of capillaries, all of which giving you a syndrome of obstructive coronary artery disease. And the second component is the functional component, which is related to the presence of both impaired vasodilation due to endothelial cell dysfunction and vasoconstriction, both of which contribute to the presence of ischemia at the small vessels of the heart. One important element when we talk about small or coronary microvascular disease is that it does not exist in a vacuum. Coronary microvascular disease is the atherosclerotic equivalent in the small vessels to diffuse epicardial atherosclerosis in the large vessels of the heart. And this is data that has been presented by Bill Roberts, the pathologist from Texas, showing here in this coronary angiogram minimal irregularities, but when you actually look at the cross sections of that coronary artery under the microscope, you see that there is a significant amount of diffuse atherosclerotic buildup in the arterial wall of the heart, despite the fact that the coronary angiogram is normal. So this is the correlate of coronary microvascular disease in the epicardial coronaries. So in studies involving patients with chest pain and no obstructive coronary disease, nearly 80% of the patients showed evidence of diffuse non-obstructive atherosclerosis by either IVUS or coronary arterial calcifications. So the majority of the patients we're going to see in practice with coronary microvascular disease will exhibit some form of non-obstructive diffuse atherosclerosis in the epicardial coronaries. And I think that's an important element to remember, and we're going to try to practice that when we review the cases later on. Diffuse atherosclerosis is not just an anatomic finding, but that finding has a physiologic correlate. What you see on the slide are pictures here of still pictures of a coronary angiogram. And in the bottom panel, what you see are pressure recordings, or FFR, along the length of the vessel. So basically, in this study, patients underwent FFR, so the pressure wire was threaded through the coronary artery into the distal portion of the coronary, and then using a motorized pullback, they did detailed pressure recordings along the length of the vessel. And when you can see here, so this is the distal part of the vessel, this is the proximal part of the vessel, and you can see that in a patient with focal coronary disease, you see a significant step down here in pressure, the typical gradient that we see on FFR, and no residual, no additional drop in pressure. So this would be the phenotype, or the functional phenotype, of a patient with a pure focal stenosis on the angiogram. On the other end of the panel here, you see a patient with no focal disease, but rather sort of diffuse disease throughout the coronary. And what you see in the pressure recording is that there is a smooth but gradual decline in coronary pressure as you go from the proximal part of the coronary to the distal part of the coronary artery. And when you think of these pressure reduction, you also have to remember that flow is dependent on pressure. So this reduction in pressure will actually lead to impaired tissue perfusion and myocardial ischemia. And then you have an important segment of the patients that have a mixed phenotype. They have a step down here, similar to the first patient, indicating the presence of a focal stenosis. But then furthermore, you see that beyond the stenosis, there's continued drop in coronary pressure, which is the phenotype of a patient with both focal disease plus diffuse atherosclerosis. Of course, this has important implications for coronary revascularization, because a stent will be able to fix the focal portion or the focal component of this pressure gradient, but it won't do much to the diffuse reduction in pressure from the base of the heart to the apex. And we will see that on PET scanning as well. So I think this concept of diffuse and focal atherosclerosis is an important concept to keep in mind when we are discussing coronary microvascular disease. What are the clinical manifestations and the phenotypes that we see clinically? As you know, coronary microvascular disease has a very long asymptomatic lag phase that eventually becomes symptomatic. A lot of the symptoms relate to angina pectoris, which has been sort of the classic definition of coronary microvascular disease. So people have referred to this as microvascular angina. But as we will discuss, angina is not just the single most specific clinical manifestation of coronary microvascular disease. Here's one example of a patient with extensive coronary disease. You can see a recent STEMI, stenting, multiple risk factors, including diabetes, nephropathy, a renal transplant in 2008, who now presents with chest pain. The patient underwent a PET scan, and you can see his PET scan shown here. There is, first of all, TID, so there's transient dilatation of the cavity on the stress images. There's also a perfusion abnormality here in the inferior wall of the heart, which appears to be reversible. And then when you look at the ventricular function, you see that from rest to stress, there is a drop in ejection fraction from about 62% to about 45% with an enlargement of the end systolic volume. Now, when we saw this, we thought this was the picture of 3-vessel coronary artery obstruction. And so we do the flows, and the flows typically confirm that the maximal vasodilator capacity was reduced. The stress flows were significantly impaired. You can see that way below 2, and the coronary flow reserve was significantly reduced. Now, much to our surprise, when we did the angiogram, the only thing we found was this moderate long segment of stenosis in the right coronary artery, but the rest of the coronaries have just diffuse disease and no focal obstruction. So this is a very severe manifestation of a combination of both diffuse atherosclerosis plus microvascular dysfunction in someone with documented coronary disease. So how frequent is this finding of microvascular disease? And Ben Murthy, from when he was a fellow in our program, did a study and showed that in patients without overt obstructive coronary disease, both in females and males, about 50% of these patients had evidence of impaired coronary flow reserve as a marker of coronary microvascular dysfunction. He showed that the severity in men and women was similar. The frequency, although the relative frequency was the same, numerically, the problem was much more frequent in women than in men. And this is consistent with the data that I showed you initially from the Scandinavia registry. Now, when coronary microvascular disease was present, it was equally bad both in men and women. So the prognosis was worse in those with impaired coronary flow reserve compared to those who have normal coronary flow reserve. So it's a syndrome that is not just of academic interest or diagnostic interest, it also has prognostic implications. So from a clinical point of view, how do we group the patients with microvascular disease? You have essentially 3 groups of patients. One group, patients without atherosclerosis. These are primarily related to patients with various types of cardiomyopathies, non-ischemic cardiomyopathies, aortic stenosis, hypertensive heart disease, and transplant vasculopathy. In these patients, which are essentially the minority of the patients we're going to see in practice, the presence of microvascular disease is not really related to atherosclerosis. In many instances, it's related to pure endothelial dysfunction. In some other cases, for example, infiltrative cardiomyopathies, they're just purely related to the presence of microvascular obstruction in the heart. The patients with non-obstructive atherosclerosis will comprise the majority of the patients we're going to see. As we said before, 80% of the patients with microvascular disease will have evidence of non-obstructive atherosclerosis in the epicardial coronaries. And this will have the largest segment of our population, including those who are obese, metabolic syndrome, diabetes, chronic kidney disease, and as we will discuss briefly, HFpEF. Patients with obstructive coronary atherosclerosis, those with stable coronary disease, also have evidence of microvascular disease. So in many cases, microvascular ischemia is a component of the chest pain syndrome and the amount of ischemia that we can measure on a myocardial perfusion scan. So dyspnea and heart failure are the other manifestations of this syndrome that are important to keep in mind. It's not just the presence of chest pain, but many of our patients, including those with obesity and diabetes, will present primarily with dyspnea as the main limitation. And here's an example of a 73-year-old woman with a history of coronary disease, status post revascularization, showing essentially presenting with both chest pain and heart failure. You can see that her ventricular function is normal. Her ventricle is a little thick. The coronary arteries essentially have diffuse atherosclerosis, but no focal obstruction. And you can see that the functional manifestation of measured by the myocardial blood flow shows significantly impaired augmentation of myocardial blood flow with severely reduced flow reserve. So this is a patient in whom the reason for symptoms is likely related to a combination of both diffuse disease and microvascular disease. So dyspnea, keep in mind, important potential manifestation of microvascular disease. In fact, the recent PROMISE heart failure preserved ejection fraction study was a prospective registry that showed a very high prevalence of coronary microvascular disease in HFpEF. As many as 75% of those patients had an abnormal Doppler flow study using ultrasound or Doppler ultrasound of the LAD coronary artery. So it's a very frequent encounter in those patients with HFpEF. How do we make a diagnosis of microvascular disease? Well, of course, it's a disease of the small vessels of the heart. So the angiogram will have significant limitations for making the diagnosis because we're not going to be able to see the small vessels of the heart. So the absence of a stenosis on the coronary angiogram will never exclude the possibility that someone has a functional abnormality downstream the epicardial coronary, what we call coronary microvascular dysfunction. So basically, the way we make a diagnosis is going to include essentially several steps. Number one, we typically are going to be looking at patients with symptoms. Even though it may be present in asymptomatic individuals, it's very unlikely that we're going to be screening for coronary microvascular disease in asymptomatic subjects. So symptoms are going to be part of the diagnosis. And we need to have an index of suspicion to be able to make the diagnosis. Number two, we used to require an abnormal exercise ECG or even a SPECT perfusion scan to make the diagnosis of microvascular disease, but now we recognize that this is a diffuse process and the ECG will have limitations and the SPECT MPI may not be very revealing because the abnormalities are extremely diffuse. And so without a regional perfusion defect, you may not be able to really detect it unless we quantify coronary blood flow, which is now beginning to be used in SPECT imaging. So direct measurement of coronary vasomotor function is the way in which we make the diagnosis. Just one word about the ETT. The ETT is a test that is useful and is often used as a first test in patients with suspected microvascular disease, but it only helps us when it's positive. When it's positive, the specificity of the ETT or the SPECT, the exercise SPECT, for uncovering or for detecting someone with microvascular disease is extremely high, but you can see that the sensitivity is extremely low. So a negative test does not negate the possibility that symptoms may be related to microvascular disease. And this is why the test is, it's not entirely, it only helps you when it's positive, but if it's negative, you still need to proceed for more specific testing for microvascular disease. What kind of testing can we do? We can do either invasive measurements of coronary vasomotor function in the cath lab, or you can measure coronary vasomotor function non-invasively with PET. It is the gold standard. MRI can also measure myocardial blood flow. Echo, as I mentioned, using Doppler ultrasound of the epicardia of the LAD can also measure coronary flow velocity and make assessments of vascular function that way. SPECT, there may be a possibility for SPECT for measuring myocardial blood flow. There's now proof of concept that using modern technology, this may be feasible. And CTFFR is potentially a tool that we might be able to use not to measure microvascular function, but actually to exclude the possibility that someone may have obstructive coronary disease as a cause of the symptom, not just microvascular disease. Why is it important to make a precise diagnosis? Because treatment success will actually be dependent on how accurate is the diagnosis, like in any condition. The CORMICA study showed clearly that when patients were diagnosed and the information was disclosed to the referring physicians, those changes in treatment were able to improve anginal scores and quality of life over patients in whom that information was kept blindly. So this was a randomized study, so all the patients went to testing, but only half of them had the information of the test revealed to the referring physician, which led to changes in management. And you can see here that the anginal score and the quality of life score was both improved in the group in whom that information was available to make a decision. So it is not just of academic interest, it also has management implications and prognostic implications. As just briefly, I mentioned that there's the microvascular disease is linked to adverse outcomes. There's plenty of data. This is a few of the studies that were done by colleagues in our program. This is work from Viviani Teccheri showing that the presence of reduced coronary flow reserve in someone without overt perfusion defects, indicating no obstructive disease, particularly when associated with impaired diastolic function, was a strong predictor of heart failure hospitalizations during the follow-up. These measures of coronary flow reserve do relate to measures of diastolic function. But the integration of the two were synergistic in identifying patients at higher risk. Nav Bajaj also show similar findings, but now going one step further and showing that among patients with extensive microvascular disease, extensive coronary risk factors, the presence of microvascular disease identify a group that had worse outcomes compared to those in whom only structural abnormalities were demonstrated. So both in terms of LV geometry, diastolic function, and systolic function by strain, you could see that the presence, the development of microvascular disease portended a worse outcome compared to those without microvascular disease. Last but not least, this is shown very recently at the American College of Cardiology and led to a simultaneous publication by Woonen Zhu and Jen Brown, showing that in patients with hypertensive heart disease, the presence of microvascular disease, particularly those that were showing adaptive remodeling, sort of concentric remodeling in the heart, the presence of microvascular disease identify patients at much higher risk for heart failure admissions compared to those with normal microvascular function. For patients who are farther along the natural history of hypertensive heart disease, now with concentric hypertrophy or eccentric hypertrophy, you can see that once you pass the early stages of the disease, the presence of microvascular disease was not necessarily a marker of adverse outcomes. These patients in general all did worse regardless of the presence of microvascular disease. So it is an important marker that is important to make a diagnosis. It makes a huge difference in treatment, and it's linked to adverse outcomes. And so I think it is not just of academic interest, but it's always an important diagnosis to keep in mind when we're dealing with myocardial perfusion imaging. This is just a summary slide showing that in any of the subgroups that were presented in the literature, the presence of impaired flow reserve, which in part relates to microvascular disease, always leads to improved risk stratification, showing here the separation of the patients at high to low risk, which is helpful in defining a course of action in terms of further diagnosis and also in terms of treatment. So we have a first case. So we have a series of PET scans. And so what we're going to do today is we're going to try to integrate a lot of the information that you received during the past 2 weeks. We're going to use PET because it's relevant to the diagnosis of microvascular disease, but it also because it provides us with a lot of information about function of the coronary arteries. And so we're going to try to use this information to integrate prior knowledge and also test your ability to use this information in practice. So okay, so here is our first patient. Here's our first patient, and Chetu, are you there?
Yes.
Okay. Would you like to read this scan? So this is a 53-year-old female who is obese. She presents with non-exertional chest pain. She's been referred for a PET scan for that symptom. Her resting ECG looks pretty normal, and she underwent a regadenoson myocardial perfusion PET scan. Here are the hemodynamics of that scan. So let me pull the images for you. And what I would like you to do is for you to make a step-by-step, interpretation of the scan. So we're going to start using the quality control procedures that we typically do, and then we're going to go systematically through the scan. Okay, so what do you want me to show first?
So first, can we look at the fusion?
Okay, and why would you want to look at the fusion?
To make sure that there's no misregistration of the PET with the CT images, which can lead to interpretation of false defects that may not be there.
Okay, so what I'm showing you here, all right, can you see the images?
Yes.
Okay, so here, the top panel are the registration of the CT and the perfusion images for the stress, and the middle panel is the same for the rest images, okay? And I'm just gonna go through. You don't have control of the mouse, but I can show you this. And what are you looking for here?
So basically looking to see that the PET images, the myocardium is registered well with the CT, and that there's not part of the myocardium that's overlying the lung fields.
Right. So an example of that would be what? This, right?
Right.
If you saw something like this, where a portion of the heart was overlaying the lung, that would be an indication that there's some misregistration and that we may need to correct it, correct?
That's right.
All right. So, all right. So it looks good to you?
Yes, looks good.
All right. So, okay.
So then we'll go to the gated images.
Gated images first. You threw me off there.
Or either way.
Functional images. Yeah, the video may be a little choppy because of the Zoom meeting. And what do you look for here on the gated images? What are you looking for?
So here we're looking to see overall what the LV size and global function are, both of which look normal in this case, in both stress and rest. And then we're also looking to see if there are any regional wall motion abnormalities.
So basically you're looking for volumes, right? To see if the heart size is normal?
That's right.
Okay. And does it look normal to you? Unfortunately, we don't have the index volumes. So these are crude volumes, and it may seem large. 90 ml may seem large, but when you normalize by the patient's body surface area, it's probably going to be okay, assuming a normal, sort of a relatively normal size patient. So, okay. So now, what now?
So now that we looked at the volumes and function and regional wall motion and all of that appears to be normal, then we'll go to the summed images.
Okay. All right, here are the summed images. And we typically look at this in black and white. So what do you think?
So then starting with the stress images, starting with the vertical long axis and looking at the true apex, it looks good. There doesn't seem to be any perfusion defects. So then if I go to short axis at the top, going from the apex to the base, I don't see any regional perfusion defects on stress. I don't see any on rest either.
Okay. All right. Okay, so that's good. And then what do you want to see now? So one thing you forgot is about, well, the LV size you already mentioned, right?
Yeah.
Anything about the RV that would be worth mentioning? Does the RV look normal?
Yeah, I think on stress, it looks like maybe I think overall it looks okay.
The RV, the intensity looks pretty good, right? I mean, this is what you typically see in the RV, not much of uptake. And why is that? Why is such a difference between the RV and the LV? Because we're looking at perfusion, right? And perfusion relates to cardiac work. And because the right ventricle pumps against a very low pressure circulation, it's much thinner than the LV, right? And as a result, the oxygen demand of the RV is much lower. So when you look at perfusion, you typically will expect much lower uptake of the tracer in the RV, right? In terms of size, looking at the RV is always very tricky because it is not in the same axis, or the shape of the RV is different than the LV. But generally speaking, my recommendation for those of you reading both either SPECT or PET is that you only make comments of RV size, particularly when you think it's dilated, when you think it's truly dilated. You know, you need to clearly see evidence of dilation. Otherwise, I would suggest not to stretch your interpretation of the RV size, because it may not be correct. But this looks normal to me, particularly the intensity of uptake looks normal. Okay, so basically you found normal regional perfusion, normal LV size, normal ventricular function. Okay, so far we're unimpressed with the scan, right?
That's right.
Okay, what else would you like to see?
So next we can look at the dynamic images to look at the flow.
Okay, and can you refresh everyone's memory about what dynamic images are? What do you mean by dynamic images?
Sure. So basically what we're looking at here is the myocardial blood flow at stress and rest. And what we do is we measure the rest flows and stress flows and flow reserve. And the units for that are in milliliters per minute per gram. And basically we're looking at the timing of the uptake of the tracer into the myocardium.
So basically, essentially what you're doing is injecting the radio tracer here at, so if everybody can focus here on the time activity curve here in the lower panel. So here's the activity measured in like kilobecquerels per ml. It's sort of a relative concentration related to the time of the scan. And you can see that at the beginning of the injection, there's no much activity, and then there is a rise in activity related to counts in the arterial blood. And then as the concentration in the arterial blood decreases, then you can see an uptake of the counts in the myocardial tissue. And you can see here in the cine images. If we could stop this for a second, and then we make a frame by frame. So this is first frame. There's not much in there. And then as you keep going, then you see the bolus of activity in the RV. If you keep going, then the RV, then you see the LV and part of the lungs up here. And then you see only LV. And then later on, you see that the LV counts disappear, and then you can see the counts trapped in the myocardial tissue. And so what we do with these images is we make sure that there's not motion. You know, here, these little bars here indicate that there was motion. And so when we process this, we corrected the motion, we realigned the images with the regions of interest. And as a result, we get these time activity curves for the stress images and also for the rest. So why do you have different peaks here? This is a green, the green curve looks lower than the green curve here in the stress.
Because the flow is higher at peak stress.
Not only that, so this is the concentration of counts related to the injected dose. And because in our protocols now we're using low dose for the rest images and high dose for the stress images, what you see is you would expect a lower peak on the low dose images because this peak relates primarily to the injected dose. And so this is expected to be lower than on the stress when we are injecting 3 to 4 times more activity, okay? And then now the tissue curves will relate to blood flow. And this is why this is much lower than this. And when you go to the flows, here are the flows on these patients. So can you walk everyone through the flow values here?
Sure. So looking at the LAD, the rest flow is 0.89, the stress flow is 2.15, and the reserve is 2.42. For the circumflex, the rest flow is 0.96, the stress flow is 2.16, and reserve is 2.27. For the RCA, rest is 0.92, stress is 2.15, and reserve is 2.33. And then the total, the rest is 0.91, the stress is 2.12, and reserve is 2.34. And just for reference values, the rest should be between 0.8 to 1 milliliters per minute per gram. And then the stress flows and the flow reserve should be around greater than 2 milliliters per minute per gram.
Okay, so here the stress flows and the flow reserve are both sort of normal, right?
Right.
Okay, so now trying to summarize all the scan findings. So this was a patient, is a middle-aged woman with obesity and another risk factor. She presented with atypical angina now, and now you have no evidence of regional perfusion defects, a normal LV size with normal ventricular function, and then when you look at the flow data, she has normal vascular reactivity with normal augmentation of myocardial blood flow and a normal flow reserve. Okay, so what does these findings so far suggest?
So far it suggests that she has no evidence of flow-limiting coronary artery disease and no evidence of microvascular disease.
Okay, so is there anything else you'd like to see as part of the PET scan?
Yeah, we'll look at the CT scan.
Okay, so it seems like she had a calcium score, and I'm gonna just show you the images here. I'm gonna try to get rid of this. What do you see? Not much calcium here, right?
Right.
Okay, so and her calcium score was actually 0. Okay, so let me just, I want you to also keep track of folks that may have questions. And so let's go down to here. So here's a summary of all the findings. Can you see the slides, Chetu?
Yes.
Okay, so she had normal size of the ventricle. The RV was also normal. There were no regional perfusion defects. Her ejection fraction actually remained the same from 61 at rest to 61 post-stress. Does that mean anything?
No.
And why is that? Because here we're using N13 ammonia, right?
Right.
And when we do N13 ammonia imaging, we don't have a key picture of the gated study here. It's a long acquisition. It's about a 10-minute acquisition. And you have really a mix of what would be peak hyperemia plus post hyperemia. And so sometimes you don't see an augmentation in ejection fraction. What you do want to see is that there is no significant augmentation of the end-systolic volume, which in this case, it isn't the case. So that will indicate a normal response, okay? And then last but not least, she has no calcium in the coronary arteries and the flow reserve was normal, okay? So now a question for the audience. Can you guys look at, based on what we discussed, what would be the best interpretation? And can you go ahead and post your answers? I'm not seeing this, so can you keep track, Chetu,
Yeah.
if you can?
It looks like the consensus is D as in dog, all of the above.
Okay, perfect. So this was easy, right? I mean, we walk everybody through, so all of the statements are correct. There's no evidence of obstructive coronary disease. We stated that the flow reserve was normal, so we're confident that there's no evidence of microvascular dysfunction. There's minimal evidence of calcified atherosclerosis. And so all of these statements are correct. And these are all things that we want to include in our report. So our report will read something like this. The myocardial PET-CT findings, myocardial perfusion PET-CT findings are normal. So basically, number one, there's no evidence of atherosclerosis or calcified or coronary calcifications. You cannot say atherosclerosis, you just say coronary calcifications because that's what we are measuring. Number two, there's no evidence of regional perfusion abnormalities. Number three, the coronary flow reserve, the stress myocardial blood flow and the coronary flow reserve are both normal, indicating no evidence of flow limiting disease or microvascular disease. And finally, ventricular function is normal in both at rest and during stress. So that will make it a very comprehensive sort of evaluation, indicating that in this case, atherosclerosis is not a big concern.
So Marcelo, so one question from the audience is, can you talk a little more about how the rest myocardial blood flow and stress myocardial blood flow are calculated?
Okay, let me just see if I can stop sharing this. And go back here. And so I'm not going to be able to show you the formula here, but I'm going to just show you the concept. If I can go back for a second to this guy. So the myocardial blood flow is a simple ratio between the maximal concentration of counts in the myocardial tissue, denoted by the color curves here on the time activity curve, divided by the area under the green curve, which is your input function. Because of what I just said, you can clearly see how critical is the estimation of the input function. If you underestimate the input function because the region of interest is placed in the wrong spot, you're going, and your peak is going to be lower. For example, if I can just put it here, and let's see what happens. So the peak here now is lower than before, right? And if I look at the flow, what happened with my flow? It went way high, right?
Right.
So because the area under the curve is the denominator of that ratio. If you underestimate the area under that curve, your flow is going to be artificially high, right? So I think, obviously it's not as simple as a ratio. There are mathematical corrections which include a correction for the extraction, the amount of extraction of the tracer that occurred during the condition that you're studying. In this case would be the stress, because of the lack of linearity between extraction and flow. That needs to be corrected. But the concept, the practical concept is not the correction. That's going to be done by the software. The practical implication of what we're talking about here is that it is critical for you to make sure that your region of interest is always placed in what I call the densest part of the bolus. So if I go through the images and I show you this, when the images, if you can see, basically what I do is I try to position my input function outside of the cavity of the LV because I don't want it to be contaminated by the LV. And I wanted to put it closer to the valvular plane here. And I always look for the counts to make sure that I capture the densest part of the curve. And you can see that now my peak went up. And if I position this a little better here, if I can, sorry, but this is too small. That would be sort of more center around the peak. And you can see here the peak, it went even higher. And so what you want is to make sure that the input function has a very sharp peak, and that then it sort of nicely comes down to almost nothing after that. And again, the area under the green curve that you see here is your denominator. So if you overestimate the input function because you put it, say, in the RV or in the lungs or whatever else, you may lead to erroneous, a higher than normal would be leading to a lower flow, and a lower than normal will be leading to a higher flow because it's your denominator. So I think that's sort of the key clinical concept that you need to remember. And this is for both the rest and the stress. So the input function is very, very critical for your calculation. Any other questions?
Are CFR values more reliable or studied more extensively using one radio tracer versus another?
In general, I would say that reproducibility of blood flow calculations with both ammonia and rubidium, which are the most commonly used tracers in the US, are pretty high. You have to keep in mind, though, that when you're using rubidium, as your generator ages over the course of the month, the images may be a little noisier, particularly if you have a large patient that you're studying. And so the reproducibility with ammonia is not affected by the age of the generator because it's always delivered a constant dose, which typically relates to the patient's weight. And so I would say in general, I think both are reproducible. The flows are comparable. There have been studies showing, and there's a good correlation between ammonia and rubidium. And more importantly, when you actually look at prognosis, the data from rubidium and ammonia has been quite consistent, showing that flows below 2 or flow reserve below 2 is consistently associated with increased risk, regardless of the radio tracer that is being used. Okay. Should we move on?
Yeah, why don't we go to the next one?
Okay. There another question?
Yeah, there are multiple questions. So let's see. So how should we interpret the graph if the slope of the peak isn't as steep as it is in this study?
You mean the peak of the input function?
That's right.
Well, you need to be careful because if the quality of the input function, okay, let me just go back here. If the quality of the input function is poor, I would recommend for you not to place too much stock on your flow reserve calculations because they may not be correct. So I think, getting used to QCing your time activity curves is pretty critical for you to have a lot of confidence about the numbers you're about to put out. Okay, so if you have a time activity curve that looks sort of very wide because the patient has poor ventricular function, obviously the area under the curve of a very wide curve will lead to very low flows, and that may be incorrect. It's just a function of the cardiac output more than the actual myocardial blood flow. So you need to be careful with that. Similar, if you're not using a pump for injection, the reason these curves look like a very sharp peak and decline is because ideally what you want to do is when you're using an injector like for the rubidium injector, that has a pump built in. If you're using ammonia, you don't want to push it by hand. You ideally want to push it via a pump because what you want is this consistent bolus that peaks and then declines. If you're injecting this by hand, the possibility of double peaks or curves that don't look as sharp as this are really there. And so I think you're always going to get a number from the PET scan. The question is, can you trust the number? And for that, you need to make sure that you become familiar in looking at the quality of your time activity curves. That's going to define the quality of this. So let's move on to the next case, because otherwise we're going to spend all the afternoon here, and there's more to see. Okay, so do I have a volunteer for reading the next? Chetu, you tell me if somebody volunteer. So the next case is a 47-year-old woman. She has multiple risk factors, including hypertension, hyperlipidemia, obesity. She actually had a coronary CT that showed significant proximal LAD stenosis, and she's now referred for PET for evaluating the flow, the significance, the physiologic significance of that stenosis. Her ECG was normal, and she had also a regadenoson PET.
Okay, we have a volunteer. Srinivas, if you want to go ahead.
Hold on one second. Let me just remember. So Lido, okay. Hold on. Okay. Okay. So who's doing this?
Hi, my name is Srinivas. Thanks for the great explanations. Thank you very much.
Okay, great. Welcome, and thank you for volunteering. So what should we do first? We start with the fusion, okay?
Okay.
And the reason is that we want to make sure that the PET images and the CT are aligned, because we don't want to have artifacts there. And so here you have axials, here you have coronals. The top panel, as I said, is the stress. The lower panel is the rest. And so now we're going to just go through the images, and what you want is the color picture to be within the cardiac silhouette on the CT, okay? And so far, so good, right? Looks good there.
Yeah.
And then on the axials, it looks pretty good there, right?
Yeah,
So
it does.
rest. And then this is the rest.
Yeah, is the apex and the right bottom frame, is the apex aligned appropriately?
You mean here?
Yes, the apex, just one of the sections. This
Here?
border,
This one?
including this one, yes. And
Now,
just if you go.
Now remember, we're not as concerned in moving below the diaphragm because it's all soft tissue.
Okay.
And when you do the attenuation correction, there are three densities that you care about. One is the lung, which is air. The other one is the soft tissue, which is everything else except for the bone, right? And the other one is the bone. So even if the heart was like here, a little lower, it's unlikely to lead to attenuation correction artifacts because you're still within soft tissue density. The problem is, when you're here, that's an exaggeration, right?
Yes.
Part of the heart here is overlapping an area that has air. And when you do the attenuation correction of a picture like this, what will happen is this part of the heart, the one that I'm pointing to, which is overlapping the soft tissue, will be corrected as it should, right, with the right densities. But then this part that is overlapping the lung tissue will be undercorrected because the computer thinks that every pixel that falls within the lung is actually air. And air has a very low attenuation coefficient. So this area of the heart will be undercorrected compared to this area of the heart. And so as a result, if you look at the reconstructed images of this, a picture like this, you will see a very large and a very dense perfusion defect, apparent perfusion defect in this part of the heart compared to this part of the heart. And then you're not going to know whether that's a real perfusion defect indicating stenosis versus a normal perfusion. Okay?
Okay.
So this is why I think, so again, the biggest problem is when it goes into the lung window, into the lung field, as opposed to the soft tissue. All right?
Yep.
Okay, so the images are well aligned. So now we go to the images. And do you usually read in color or?
I mean, I'm a first year fellow. I haven't done nuclear rotation, so I'm learning.
Oh,
so both are good for me.
You're a brave guy.
Oh, you've created such a good environment. So.
Okay, all right. So here are the images. I'm gonna show you color because people will say, he's so boring. He shows black and white. All right. So what do you think?
So going from apex to base, there is it grossly looks okay. I mean, maybe some apical and mid inferior persistent defects on the cross section views.
So I would suggest the following. You always have to have a systematic approach to this. And so what I suggest is you begin by describing the size of the heart, number one, particularly the LV. Mm-hmm. Once you have a handle on the size of the LV, then you're going to try to assess the RV, and sometimes you need to unzoom the images. And, I'm going to put it like this because it is going to be easier for you. Basically, the LV size looks pretty normal. Sometimes we don't need to guess what the LV size is on the summed images. We can actually go to the gated images, and as we did in the previous case, we can simply look at the volumes. And in this case, the volumes, again, these are the raw volumes. Unfortunately, I don't have the normalized volumes, the volumes that are divided by the patient's body surface area. I assume, since this patient is obese, that probably is very large and the volumes will be relatively normal. But again, we look at the gated images to try to guess what the size of the ventricle is. In this case, we're going to say is normal. Then we're going to look at the RV, and the RV looks pretty normal in terms of size and also in terms of intensity. You can see that it's a very pale, very faint line here, which is normal. That's what the RV normally looks like. And then we look for defects, and the reader was saying that there's apparently a defect here. I'm going to try to make it a little bigger. And you can see that at the apex, there's a little bit of a loss of counts here. It's kind of also present here. And typically this relates to the apical thinning and a physical issue with nuclear imaging, with any imaging, but in particular nuclear imaging, which is called partial volume effect. If you want to know, is this a true defect? One thing you sometimes can do is go to the gated images and go through the various parts of the cardiac cycle. I go now to sort of end systole. And in end systole, I see that it almost disappeared. Okay. And that means, the thickness of the myocardium is approaching now the spatial resolution of the scanner. So you're not catching pixels outside of the heart muscle tissue that will dilute your counts and will make it look like a defect. So in systole, you can test whether or not that is a defect, okay? And it looks you know, it's still not perfect. And I think this case has a little bit of motion. You can see that there's some blurring of the inferior wall. And I think there's a little bit of motion here. You know, let me just check one thing here. No, okay. But I think for the most part, this is gonna be interpreted as sort of apical thinning and not a real perfusion defect there. Okay, let me just see. Yeah, well, it may be borderline, you know, I don't know. It may be borderline there. You know, there may be some mild perfusion abnormality here in the apex, okay? But importantly, the rest of the anterior wall looks pretty good, right?
Yes, it does.
There's really nothing here and nothing there. So I think for the most part, we have a possible small defect here. Okay, so we looked at ventricular function, and we have said, where's the ventricular function here? Here. The images looked, regional function looked pretty normal, right? And I typically do this if for regional wall motion, I typically read the images like this because they're a little easier to read. And basically what you do is you look at the endocardial border of the images and make sure that there is normal and symmetric you know, motion all around the myocardium. And you can see on these images look pretty smooth, right? There's good regional wall motion everywhere in the heart, okay? The ejection fraction goes from 61% at baseline to 67% during stress. That's very reassuring. We didn't see a perfusion defect. The ejection fraction is normal and it rises normally with stress. So now the next thing we can do is we can look at the flows, right?
Yes.
And as we discussed, we're going to take a quick look at the images to make sure that, you know, we have already processed the images so that there was a little motion that was already corrected. And you can see that for the most part, you know, they're, you know, pretty good. You can look at the curves and they look pretty straight here.
Yes.
Again, a nice peak that comes down on the input function. And so I think we can pretty much rely on these flow data. We're going to look at this. And so here are the flows, you know.
Yeah, the rest is at the rest is at 0.58. LAD territory is 0.58, 0.61, 0.57, and 0.58.
Yeah, people say, what are the normal resting flow values? Anywhere between 0.5 and 1.2 are relatively normal values because the resting flow will be related to the patient's heart rate and blood pressure.
Yes.
If someone is on beta blockers and has a very slow heart rate and a low blood pressure, your flow is going to be lower. Rate of 85 at rest and a blood pressure 140. That patient is going to have a higher resting flow. So the resting flow, for the most part, is going to be related to the resting hemodynamics at the time of the scan. So you need to look at the patient's heart rate and blood pressure to make sure that this is approximately where they should be. All right. And
yesterday we had one concept where we could calculate this by the product, the heart rate blood pressure product by 9,700.
Right. So in this case, we don't really need it because this looks pretty normal. We use the correction particularly when the flows are higher than expected. And in those cases, we suspect that there is a problem where the patient is either hypertensive or or has a fast heart rate, and in those cases we do those corrections. The stress flows are close to 2, certainly almost 1.8, which is kind of a number that we use. Above 1.8 is relatively preserved. So the LAD, remember that we started off, this patient had a CT with a lesion in the, oh, I didn't show you the CT. I'll show you the CT in a moment, but there was a concern about significant stenosis in the LAD, okay? Yep. And so the LAD has here normal stress flow, right? 1.9 is almost, it's pretty normal. And the ratio, the coronary flow reserve is 3.28, which indicates the absence of a flow limiting stenosis. And then the circ and the right coronary is a little lower here. It may indicate some atherosclerosis, but the flow reserve is close to 3, so that we're not concerned about high risk obstructive disease. So this is a patient that may have some element of non-obstructive atherosclerosis and you will see the CT scan in a minute, okay? But for the most part, the flow reserve is good, so we're not concerned about that little defect that we saw in the apex. You remember that we were concerned about? This, to me, it looks pretty normal, so I would not read it at all. I would say there's no definitive evidence of perfusion defects, and the flow reserve is normal. So I'm saying this patient does not have evidence of obstructive coronary disease. So one additional element was that you always look at on PET-CT is something that comes for free, which is the CT. And essentially what we look for is we look for evidence of calcified atherosclerosis on the CT. This is a non-gated CT, so it's somewhat limited. It's not like the usually crisp CT you use with gating, but you can see here this density here. Yeah. And this density corresponds to a lot of calcium here in the proximal and mid portions of the LAD, okay? And you can see that there's also calcifications in the circumflex going into the AV groove here. So there's a lot of calcification. So in the report, we will say there is, first statement is there is extensive calcified atherosclerosis, which we sort of knew because that's the reason the patient was sent here, because the patient already had a coronary CT angiogram, which I'll show you in a second. Second conclusion is there's no evidence of focal flow limiting disease by either visual analysis of the images or by quantitative analysis, okay? And the third element is that ventricular function was normal. Okay, so that was a great job. Let me just go back here. Here is the CT angiogram that sort of prompted the PET scan. Can you all see it?
Yes.
So you can see here, this is the left main, this is the muted. Am I muted?
No, you're not.
I'm not. Okay, sorry. It said on the screen that I was muted. So what you see is extensive calcifications in the proximal and mid portion of the LAD. The circumflex, there are some spotty calcifications, but it looks okay. The lumen and the right coronary also has some mild calcifications here in the mid portion and the proximal portion, but overall looks good. So the key territory that they wanted us to evaluate was the LAD. And essentially we conclude that there's no flow limiting lesions in the LAD based on our PET data, okay? So, okay. And okay, so here's the question. Can you guys vote? Okay, Chaito, are you there?
Marcelo, there'll be a slight lag in response because ASNC has to unmute each person individually.
I'm sorry.
B as in boy, diffuse non-obstructive coronary disease.
B as in boy. Okay, good, good. So I think, you know, you never want to report this as a normal scan because there is a lot of calcification. And so the scan is not normal. There's calcified atherosclerosis, but there's no evidence of focally obstructive disease. So diffuse non-obstructive atherosclerosis is the most and the best interpretation. Okay, great. Thank you. All right. So I got another one here. It's a 72-year-old female with hyperlipidemia. Let me just see, make sure that I know who this patient is. Hyperlipidemia with chest pain and dyspnea. She comes in for a PET scan. Her ECG shows sinus bradycardia, no specific STT wave abnormalities. She had normal hemodynamics on PET. So her PET scan, I'm gonna try to go here. All right. Any volunteers? No volunteers.
We have 4 volunteers. I'm not sure
Okay,
who we should pick.
Okay, so just use your random pick.
Okay, we will unmute Marcel since that person volunteered first.
Okay, good, good. All right. So who is it?
1 second, unmuting them right now.
Okay.
Okay, they should be unmuted.
Hi there, this is Marcel. I'm at St. Luke's here in Pennsylvania.
Okay, how are you?
Doing good?
And let me just correct this because this is wrong. Stress, rest. Okay. So you're gonna disregard this one here because it's not the correct CT. So we're gonna just look at this one. All right, so in this one, only look at the top, disregard this one here because I don't have the correct CT.
Gotcha. So,
So I'm gonna go through this.
yeah, so I think it's pretty well aligned. I don't see any myocardial tissue outside of where it's supposed to be or overlying with the lung tissue.
Okay, perfect. So let's go to the images. Sorry. What do you think of the images?
So I think looking at the stress first.
But what do you think of the overall quality first?
I think the overall quality appears to be good.
I think, honestly, I think it's very poor. And I'll tell you why. See this fuzziness here?
Yes.
That's never normal. The heart is supposed to be a perfect Cheerio, a perfect donut. And you can see a lot of sort of grayish here. And so almost you see a hot spot here. You see another hot spot here. And then you see kind of fuzziness in the anterior wall and the inferior wall here, where my pointer is. Look at rest. Look at rest is supposed to be pretty good, right?
It's more well-defined.
More well-defined.
Clear. Yeah.
And so anytime that you see this fuzziness, you need to be suspect of what?
So like motion with stress potentially?
Exactly. And so we just went through this and you say, hey, wait a minute, you just told me that there was good registration, right?
Right.
But we haven't checked the motion yet, because the motion can occur all across the different frames of the scan, right? Remember, the scan takes 10 minutes. And so we need to be able to see if there's motion along the 10-minute scan. And so the point of this case was to really how to troubleshoot patient motion. The fusion images tell me that the summed images that I fused are okay. But what I need to know is, are all the images that are collected in the summed images, accurate? And so the way we do that is we actually use this, not because I want to look at the flows, but because I want to see if you remember that this allows me to see a cine. And what I'm going to do is I'm going to reset this. So now I'm going to take a look at the cine of the images on the top, which are my stress images, okay? And what do you see?
So basically it's no longer aligned, so it's moving.
You can see
there's
a lot of motion all across the scan, right? The heart jumps up and down, and there are places where there's even lateral motion. And so the question is, what do we do now? Because, the summed images, essentially the ones you use for interpretation, when we reconstruct the images, we'll say, okay, so we don't want images here, right? Because it has the blood pool where my mouse is. So what we do is we will sum all the images after we pass the arterial blood phase. And we will sum all the images beyond that point, right? But if there's a lot of motion, I may need to go further and further and sum the images where it looks more like a straight line. See that there are dips here and so on?
Yes.
And you can actually do this by going frame by frame. And then you tell the text, okay, by default, they will typically eliminate the first 90 seconds because it has all the arterial phase. But if there's motion, you may need to go further down here to be able to capture the images that are not, that do not have motion. And in this case, we did that, and it turned out that we had to go and do 5 minutes. So basically what we did is we eliminated the first 5 minutes of the images, and we got this picture right here. And even though it's not perfect, you can still see a little bit of shadowing here. I think it's going to be interpretable compared to the original picture that you had. Okay?
Sounds good.
So now you can go through the interpretation.
All right, so looking again first at the stress pictures.
What do you think about the size of the heart?
Just visually, it looks a little bit bigger on stress compared to rest, maybe slightly.
Okay.
but at rest, the size appears fairly normal.
Okay, and the RV looks normal?
Yep, a little bit of enhancement, which is kind of like we discussed earlier,
Okay.
but not a normal enhancement, and it doesn't look overtly enlarged.
Okay, all right. Go ahead now and read it.
In terms of the perfusion, so looking at stress, there is a slight decrease in counts in the inferior wall from apex probably to mid, possibly from apex to the base in the short axis. Looking at the long axis, maybe a very slight decrease in counts there as well. And when we look at rest, that seems to completely resolve. So slight
So this is what you're
reversible
talking
defect.
about? Is this what you're talking about here?
Yes. So
Okay.
and in the black and white, it seemed to be more in the inferior, but with this, yeah, now a little bit in the inferior lateral as well.
Yeah, yeah. We need to be a little careful because there's a hot spot here in the septum.
Mm-hmm.
There's a hot spot here. So we'll have to see. We'll
relatively,
have to see,
yeah,
exactly. It's just the way the images get normalized, you know. So I think in this case that I see exactly what you're talking about here, but maybe in order to avoid overreading this, we may want to go and look at the flows. And because I screwed up now the issue with the flow, so what I want to do is go back for a second to my PowerPoint. Hopefully I have the flows after we did all the motion correction. And let's see. Okay, so I don't know if you
so a little bit tough to see, but from what I can tell, that's better.
So these are the flows here. So first of all, the time activity curves looks fine, you know, with a sharp peak, lower peak at rest, and then the images, the lines here look pretty straight. And then here are the stress flows, 179, 171, 166.
Yep, so rest, all the territories are in the normal range, so 0.7 to 0.8 for all of them. And then they augment appropriately with stress, so more than twice what it is at rest, the flow. And the reserve is all above 2.0 with the total being 2.3.
Yeah. So the reserve, it looks pretty normal. The stress flows are slightly lower than what we would like them to be. And so the question is, what could this be? We will take a look at the calcium images. Sorry, same picture.
Do you like to see them like above 2, regardless if it's like a doubling from rest in terms of flow with stress?
The flow reserve, you mean? Yeah, the flow reserve, I'd like, for the stress flows.
The stress flows.
Yeah, the stress flows are a little lower, mildly lower, and it could be related to atherosclerosis or microvascular disease, but let's take, I'm sorry, that's not what I wanted. Here is the calcium images. And if I can, so the patient had some calcifications already highlighted here. So here's the, okay, so here's the left main.
Yeah.
This is the proximal LAD. There's some calcifications there. And then the circumflex looks pretty good. And then the right coronary had some calcifications here. I think I passed it. We've seen it before.
Yes, I saw it a couple times. It did.
Yeah.
As well as the descending.
Yeah. So there's some. So the flows, the stress flows slightly reduced, may be related to that issue of diffuse athero or perhaps mild microvascular dysfunction. But the normal flow reserve suggests that it's not likely to be high risk coronary artery disease. Okay. And one additional element that we typically do, is if I zoom in here, can you see the polar maps?
Yes.
And so this is the stress polar map. This is the rest polar map, okay? And you could actually look for gradients across the walls in flow. And, as I showed you on the slides when we were discussing diffuse disease, you see that in diffuse disease, the pressure that you measure with a pressure wire actually drops, right? And the same physiology will be seen with flow, because flow and pressure are linearly related when you infuse adenosine. When you reduce coronary resistance to a minimum, flow and pressure are linearly related. So you can change, if you wanted to sort of estimate a fractional flow reserve, you could actually use flow instead of pressure and figure out whether there is a gradient in pressure across the walls. And you can see just visually looking at this, there doesn't seem to be a gradient, a significant drop in flow. And this will indicate to me that this may be primarily a factor of sort of mild microvascular disease that is usually a diffuse process. It doesn't have a gradient, okay?
Mm-hmm.
So again, this can be helpful as a complement of what you do by looking at the overall flow in the territory. It's just looking at the segmental values and figure out if there's a gradient in flow from the base of the heart to the apex.
Mm-hmm.
If there are significant gradients and you don't see a perfusion defect, it could be diffuse disease. If there's a significant drop, it may be obstructive disease that you're just not seeing as a defect. Okay?
I see.
But the flow reserve was pretty, remember that we wanted to look at this because we were not clear about that perfusion defect that you were reading. And now with this data, I would say, if there's, there may be mild ischemia in the inferior wall, but I would say it's probably nothing because the flow reserve is still pretty good. So
Right.
I would read the scan as a probably normal scan, okay? This is the flow data. Okay, so here's the question for you guys. Can you go ahead and vote? All right, so anyone can read me back what people are saying, because I'm not seeing that.
So pretty much everyone is saying C.
Yeah, okay, good, good. So I think we gave that answer away, right?
Yes.
Okay, so, all right, so let's look at this scan. Maybe I get another volunteer. So this is.
There's a question about motion correction. So
yeah,
can this be done post-processing in the reading software, or does it need to be done on the camera console, processed and sent again?
Camera console. You can only spot where the motion occur, but the images have to be reconstructed, and that is always done at the console. You cannot do it at the reading workstation. Anything else? Okay, so here's the next patient, 69-year-old woman with aortic stenosis. She has no known coronary disease. She's part of a research study, but I think there's an important finding here that I want you to help me review. She had sort of non-specific STT2 wave abnormalities on the ECG. I'm gonna just go back to the images. And okay. All right, let's see. Do I have a volunteer?
I'll be unmuting Rana. He was the first to volunteer. Just 1 second.
Okay.
Okay, he's unmuted now.
Okay. Hi.
Hi, this is Rana. Thank you so much.
Yeah. Thank you for volunteering here. Okay. So let me just move these guys down here. All right. Oops. There's a little bit of a misalignment here.
So yeah, we're starting.
Oh, this is why, because they aligned it with the stress. Hold on. This is the one we want. How's that looking?
Looks much better.
Looks better, right? And here it looks pretty good. And this is the resting scan now.
Yeah, I don't see any. I think this is correctly aligned.
Okay, perfect. So we go back to the images. Let me just okay, so
as we discussed, starting off looking at the rest and stress images, looking for the size of LV, looks dilated.
hold on 1 second. Just because I'm showing you the same images. All right, so let me just find you the rest images. All right.
So looking at the LV size, it's dramatically bigger or larger on the rest scan. I mean, is it aligned? Okay, the top is stress, right? Or,
Yeah.
okay, so the stress portion, it looks enlarged compared to rest.
Significantly enlarged.
Yeah.
Yeah.
I
okay.
don't see RV.
Yeah, the RV looks good, right? And just see if we can. Here's the RV.
Yeah, it doesn't look significantly large. It looks like less than the LV. It's probably normal size.
Okay. So the striking finding is the difference, right, between the stress and the rest images?
Yes.
How do we call that?
TID?
Yeah, we call that TID, significant TID. In fact, the number is not listed here, but I recall it was like 50% larger. Mm-hmm. So it's like a TID of like 1.5.
Right.
Okay.
Now we're going to look at the regions. I'm looking at the stress portion to begin with. I see some defect in the inferior, moving from the apex towards the base, inferior region, mid to distal inferior, and
right here.
Yeah, infraoapical region.
Right.
And then you also see this into the apex.
Right. So the apex here, right? The distal inferior and infraoccipital here.
Infraoccipital region as well. So it's like almost involving all the apex, except limiting the anterior and lateral portion.
And here on the mid-ventricular images, it looks homogeneous, doesn't it?
Yeah.
And at the base, it also looks homogeneous. So it's essentially TID and sort of a distal, sort of apical and segments and apex that look abnormal, right?
Yeah.
So if you want to do in color, you could see that this is the area where we see the sort of abnormality. Okay. Okay, so what else should we look at?
Gated images.
All right, let's see gated images. And stress gated and the rest gated.
So the defect in the inferior and infraapical region remains.
Yeah, in systole.
Yeah.
Yeah. Yeah, it's probably a real defect.
And same with the apical septal region as well.
Now, look at the ejection fraction. It goes from 70% at rest to 52% during stress.
Yeah.
That's abnormal, right?
Yep.
And then the end systolic volume goes from 30 mLs to about 66 mLs. So there's TID and there is a drop in ejection fraction with an enlargement in the end systolic volume.
Right.
Right. Now, does the drop in ejection fraction to you look out of proportion to the amount of ischemia that you just read on the scan?
It does.
Because you only read the apex and the sort of the apical segments, right? So this seems to be much more than just that area of the heart, right?
Yes.
Looks like there's probably a lot of subendocardial ischemia throughout the ventricle that we're not seeing. But anytime you see a TID with
would you comment on like diffusely, the LV looks thinner in the stress portion compared to the rest.
Right.
So there's
Exactly.
decreased counts all over.
Yeah, exactly. So that denotes subendocardial ischemia, but subendocardial ischemia could be due to coronary disease or could be due to other processes, right?
Right.
So, but if you're reading a scan and you say, okay, number one, there's significant TID. Number two, there's at least one territorial defect that I read. Number three, there's a significant drop in ejection fraction, right?
Right.
So far we have elements of a high-risk scan, right?
Right.
You review those in a previous session, right? The defect is moderate in size, but there's TID, there's a drop in ejection fraction. Let's see what else we have. And let's see if I can, and if we have the flows. And okay, rest dynamic. And her flows are, here are the stress flows. Can you see them?
Yes. So I'm looking at rest flows and stress flows. Oh, actually, these are only rest ones, right?
No. Here, see my mouse?
Yes.
These are oh, I'm sorry, they're mislabeled. Rest 1 are truly stress flows.
Okay.
Rest 2 are the resting flows.
Right. So the true rest look fine, but then the stress ones are also not what, they're kind of low. They're not augmenting.
They're very low.
Yeah.
And as a result, the ratio, the flow reserve here
is 1.46 total. This is pretty low.
Yeah. So basically, we have all these elements point to a high-risk scan, right?
Right.
And so how would you report this?
I would mention TID. I would mention the apical inferior defect, and then I would mention drop in EF and consistent with high-risk scan.
Okay, that's pretty good. So
likely multivessel disease.
Okay. All right. So can you guys go ahead and answer that question? here are your options.
A.
Okay. A is what most people, and I completely agree. When you're reading the scan, you need to read it that way. This is an elderly woman with aortic stenosis, so you need to know, is there also coronary disease here? Now, she got cath, and she has normal coronaries. So what she has is severe critical aortic stenosis. And this is sort of an example of what aortic stenosis can do to the heart, right? Because the stenotic valve acts as a diffuse 3-vessel stenosis, because, you know, the gradient is not at the coronary level, but is before the coronary level. And so you lose perfusion pressure, and as a result, the blood flow drops. And the drop in flow leads to an impaired in coronary flow reserve. Okay, so this is to remember that severe small vessel disease plus obstructive, you know, she also has severe LVH, which is also a contributor here. So probably the reduction in flow and the flow reserve is a combination of the aortic stenosis plus a notion that she has microvascular disease. But here, all of this looked like severe 3-vessel obstructive coronary disease. Okay, so this is just to illustrate the functional abnormalities of the microvasculature can have on a myocardial perfusion scan. Okay, so the notion that anatomy and physiology can be truly uncoupled is exemplified in this case, where the angiogram would have never predicted what you saw on the functional study.
Did this patient had a CAC score or cardiac CT with this?
Let me just see. Hold on. Let me just. I think I don't know if she. No, she doesn't have. But she has a CT. Let's take a look at the CT. Okay, CT. Okay, so here's her CT scan transmission. She has some calcification here in the LAD. It's not horrible. That's the aortic valve, right?
Right.
And yeah, she has, I would say, modest calcification. This is MAC. Okay, this is just the mitral valve. So she has, you know, mild to moderate calcifications in the middle AD. All right.
Right.
So, so I think, okay, well, I think we run out of time. I will just spend maybe 2 minutes in questions if folks have any questions. And I'm sorry that we were able to get through only a few cases.
Thank you, Marcelo. Amazing lecture. Just to let you know, while you're answering questions, I'm going to start a screen share. So don't be surprised if you lose your images.
All right. So anybody has a question?
Yeah, Marcelo, so can you comment on coronary flow capacity, pros and cons, and any particular examples where its use could provide additional value?
Okay, so basically what we have been doing in the review of these cases is essentially looking at the so-called coronary flow capacity, which is a measure that combines the stress flow and the flow reserve. And these two axes that you have, if you can think of a scatter plot where you have the stress flow or the flow reserve in the y-axis and the stress flow in the x-axis, will give you, you know, by putting the combination of the values that you see in each patient, will actually give you different patient risk that you can see on a follow-up. And I think both are important to try to make sense of what you're trying to see on the scan. Now, the measurements or the cut values that Dr. Gould has proposed may work well with his software, but has not been really replicated in other papers. And in fact, some of the cut points that he uses for sort of the patients that benefit from revascularization are extremely low, you know, like peak flows of 1 and flow reserve like 1.2. So I think the work from Krishna Patel from Kansas City show that flow reserves in the order of like 1.6, 1.7 patients, those patients benefit prognostically from revascularization. But the concept of flow capacity is useful because it forces you to integrate both the flow reserve and the maximal flow. And the maximal flow I always use as an indicator of what may be going on in the epicardial coronaries, and the flow reserve is more about the integrated system that integrates the microvasculature. There's a paper by Ankur Gupta, which was published in Circulation in 2018, where we did a follow-up on a lot of patients using this concept of flow capacity. And you can see that there are, by plotting the maximal flow and the flow reserve, you can arrive to different risk groups across the patient, across the patients that you have. So I think you need to use both. And I recommend that you guys go and read those papers, both Krishna Patel's in European Heart this year and Ankur Gupta's from 2018.
So first of all, thanks to all of you fellows in training for all that you're doing these days at these tough times, risking your lives at the front lines of taking care of patients with COVID-19. So we're really delighted that you chose to join this virtual ASNC nuclear cardiology elective despite the really tough times. Just want to remind everyone there's a lot of opportunities for fellows from ASNC, a number of awards and grants. If you're interested, please reach out by email info@asnic.org. This virtual nuclear cardiology elective is made possible by the amazing staff at ASNC. Believe it or not, the program was put together and unfolded in 5 days from start of the idea to the thought. So I just wanted to share a brief video of the ASNC staff here.
I love ASNC because we support the future of nuclear cardiology.
I love working at ASNC because everything that we do here helps improve patient outcomes in cardiovascular disease.
I love ASNC because of the members and the staff that I've worked with. The group of planners that I have worked with over the years have become dear friends, as well as people that I can call on in a pinch if I ever need a new speaker.
And I love ASNC because we care about quality. Our members care about quality in delivering the absolute best treatments for their patients. Our members care about quality in developing and creating the utmost world-class events and programs to help raise the bar so that everyone is delivering the absolute best treatment and care for each and every patient. And that's why I love ASNC.
I love ASNC because we work 100% for our members.
I love ASNC because our members are so dedicated and passionate about our mission and improving healthcare through our many quality initiatives.
I love ASNC because I love the support that all of our international members give to help promote nuclear cardiology worldwide.
Hello, I'm Kathy Flood, the CEO of ASNC. It is such a pleasure to work for members that are so passionate about what they do and about nuclear cardiology and the bright future that nuclear cardiology has in front of it. On behalf of the ASNC team, it is such a privilege for us to be working for you, and we enjoy it thoroughly.
So thanks to all the ASNC staff under the leadership of Kathy Flood, Veronica Parkin, and others. Last slide here is to really thank the amazing faculty and fellows, all of whom were really busy with the COVID-19, dealing with new schedules and all of that. But this group of amazing faculty and fellows from several institutions got together to teach all of you about nuclear cardiology over the last 2 weeks. So with that, I close this 2-week virtual nuclear cardiology elective by ASNC. Thank you all to all of you for joining and to all the faculty and fellows for their participation. Thank you very much.